my name is David Yashar from Harbor-UCLA Medical Center. I'm a PGY 2, and I will be presenting my case report titled It's More Than It Seems, a case of Blastic, Plasmacytoid, Dendritic cell Neoplasm, also known as BPDCN. To begin, BPDCN is a rare hematologic malignancy with an overall aggressive clinical course. It represents 0.44% of all leukemias and it has a predilection for skin and the lymph nodes, and later on in the disease process it has bone marrow and CNS involvement. The presentation is usually ambiguous skin findings that are often confused with inflammatory infectious processes, which usually delays the diagnosis. Limited information exists in regards to evaluation and management owing to the disease's rarity. To begin, a 64-year-old male presented to his primary care doctor with 1 month of diffuse, non-pruritic purple macular rash. He also had weakness and fatigue at that time. As we can see in Figure 1 and Figure 2, Figure 1 is a diffuse bruise-like macules that are often non-pruritic in nature that can be found in BPDCN, as well as in Figure 2, these nodules, which can also involve the entire body and can be seen in BPDCN. However, neither of these are specific or common, as there are multiple other skin findings. At that time, these skin findings were thought to be secondary to allergic or an inflammatory process. The workup was negative, and the patient was told to follow up with dermatology. He presented 1 month later to the ED with dizziness, fatigue, and shortness of breath. His vitals at that time were remarkable for tachycardia at 115. His blood pressure was 111/74, and he was tachypnic at 22. His exam was remarkable for conjunctival pallor, tachycardia, multiple raised macular lesions, which involved the whole body but spared the palm, soles, and genitalia. His labs were significant for pancytopenia, and the differential was 30% monocytes, 5% metamyelocytes, and 2% myelocytes. He subsequently got a bone marrow biopsy, which on immunohistochemistry showed CD4 positive, CD56 positive, and CD123 positive cells, which was consistent with BPDCN. He received 2 cycles of hyperCVAD therapy, including intrathecal methotrexate and cytarabine, and is now being transitioned to stem cell transplantation. Overall, BPDCN is a challenging diagnosis, which is often delayed as patients present with vague cutaneous findings that are usually confused with other dermatologic conditions. As the disease progresses, it usually disseminates and involves the bone marrow and CNS. Tagrix is the only FDA-approved treatment. However, randomized clinical control trials are lacking given the rarity of the disease, and in our case the patient had hypoalbuminemia, which precluded the use of Tagrix, as this can cause a rare but severe syndrome called Capillary-Leak syndrome. The takeaway from my case is that this can be challenging overall for the primary care doctor or an internist, given the rarity, the vague skin manifestations that can represent other inflammatory infectious disease processes. However, in an elderly patient such as ours with vague symptoms and extensive skin lesions, hematologic malignancy should be considered leukemia. This disease overall has an aggressive clinical course and poor prognosis, making the diagnosis crucial. Thank you so much.